So we're going to talk about the role of immune checkpoint inhibitors in non-metastatic non-small cell, and then we'll talk about metastatic disease in patients without a targetable mutation. Really interested to hear about some of the new therapies that are coming out, particularly your thoughts about ADCs, which we've been talking about all day long. So we'll just start out maybe just taking a step back and asking Corey to comment a little bit. Before you get into the data, maybe just chat a little bit about kind of how the use of immunotherapy in the localized setting, neoadjuvant and the adjuvant setting, from a broad macro perspective, how that has evolved over the last couple of years.
I wouldn't say it's evolved. It's like a tsunami. 4 or 5 years ago, we knew the studies were ongoing, but it had really not ventured on the scene. Pacific was already there, so we sort of worked backwards from metastatic disease to locally advanced and now the resectable setting. I was a skeptic initially. There was no phase 2 or phase 3 data in advanced disease, but Durva clearly tripled PFS, as I'll show you, and that translated into survival advantage. And we are starting to see the same now in adjuvant and even more so neoadjuvant or periadjuvant. Virtually every study that's done in this setting is positive.
So Eddie, just kind of curious in terms of when you think about neoadjuvant IO nowadays.
We really think about neoadjuvant IO in most of our surgical cases. I think in the stage 1 cases, that is a place where often, certainly in the stage 1A, where we've been more reluctant. But outside of that, our surgeons have been very enthusiastic. Now that may be an academic center bias, but there has been a lot of enthusiasm amongst our surgeons about these approaches.
Corey, what do we know right now about the effects, if any, deleterious effects, if any, in terms of IOs, in terms of the ability to do surgery, and on the other hand, the ability to reduce the amount of surgery by downstaging?
So initially there was major concern that it would create perioperative complications, enhanced fibrosis, as we had seen with chemoradiation in the same setting. That's fallen by the wayside. My surgeons, who were initially quite skeptical, have embraced it, particularly in 3A, less so in 2 and 1B, so some variations across academic settings. In select studies, we are seeing lower pneumonectomy rates and a higher percentage of what we call R0 resection, so clean margins, proximal nodes clean. So it's actually improving surgical access, reducing the amount of operation that needs to be done.
So Lowell, I'm curious for your perspective. Of course, you have multiple perspectives, including an academic perspective, but in terms of your work here in the community, how you see surgeons, rad oncs, et cetera, sort of reacting to these new data of IOs in the neoadjuvant and adjuvant setting.
Yeah, I think there definitely is a lot more acceptance than there was just a few years ago. On one hand, the thoracic surgery perspective is changing. So, when I first came to Florida, I mean, it was all done by people who were still doing, heart operations, and obviously that was the large majority of what they were doing was cardiac bypass surgery, and then there was a little bit of lung cancer surgery in there. Now, at least where I practice in Fort Myers, we have dedicated thoracic surgeons, that's all they do. And we do have multidisciplinary meetings. Now, not every patient gets to, except in some academic centers, I would say, not every patient is going to get to a multidisciplinary pre-op conference, but we do have them. And I think just having those around and getting people on board, I mean, it's kind of similar to the old days. I see a lot of breast cancer, obviously, too, and the way it was like a couple of decades ago in the breast cancer world, where now you're seeing more specialist surgeons and surgeons that are more recently trained. And so I think it has come around.
Corey?
Completely.
I echo that. You mentioned multidisciplinary tumor boards and conferences. The 3A patients in particular really need that. It takes a village. There are data from the UK and from China that patients who are evaluated in the multidisciplinary setting, frankly, do better. They have better survival. So that sort of multidisciplinary input that occurs in that setting is key, I think, to better outcomes. And really, ultimately, we're talking about collaboration between pulmonologists, interventional radiologists, surgeons, medical oncologists, and select cases, radiation oncologists. They all need to be at the table.
So yeah, I think it was yesterday I was saying that, I kind of been disappointed that, with the revolution in telemedicine, it kind of seems like we got all ramped up and now we're sort of kind of going back to what, and particularly interdisciplinary is not very easy to do in the community. I mean,
Right.
tertiary center is one thing, but Lowell, to try to pull this off in the community
Yeah,
with these different disciplines.
It is difficult, but not everybody's in the same building. I mean, in the academic setting, everyone's in the same building. You just say, we're having a free lunch, everybody come to the conference, or a free breakfast. And it's not really like that in the practice world.
All right, well, let's get into a case here. Corey has a 68-year-old patient, a heavy smoking history. What happened there, Corey?
Cough, minor wheezing, chest x-ray showed a right upper lobe nodule. Subsequent CT and PET show what you see there. About a 3-centimeter lesion, moderately elevated SUV in the primary. Vague precarinal node. The films here don't really show it well, but the borderline SUV. PET, brain MRI, otherwise completely negative. No other sites of disease. CT-guided biopsy of the right upper lobe mass, adenocarcinoma, TTF1 positive, therefore lung tumor, bronchibus positive in that precarinal node and negative elsewhere. PD-L1 50%, EGFR and ALK are both negative.
So, Eddie, you want to take a crack at how you might think through this situation?
Sure. So this is a patient who has a precarinal lymph node. This obviously historically has been an area of significant concern. I think one of the things that that Corey alluded to is that there is some reluctance in many surgeons in patients who are unlikely to need systemic therapy, for instance, to incorporate a neoadjuvant approach. But this is a patient where it appears very likely that this patient will eventually be obtaining some sort of systemic therapy. I think the PD-L1 of 50% is certainly encouraging. We, with one outlier study, we have generally seen across all studies and really all stages that these patients with high PD-L1 expression are the people who derive particular benefit. So I think this is a situation where I would be certainly comfortable at looking at neoadjuvant or perioperative approaches in incorporating immunotherapy.
So you would choose 3.
So I think that in general, I would look at an induction chemo IO. That would be my primary approach.
So what happened?
3. Chemo IO, the patient's still on treatment, so we'll see what happens with the final path. I'm hoping for a path CR, but we don't know, of course, until the final resection.
Can you, I'll go back to Eddie, can you kind of talk a little bit about the way you think that through and why you came to that conclusion?
Sure. So, again, our surgeons have been particularly aggressive about the neoadjuvant approach. But one of the things I always get concerned is what if I got the surgical results, would I still go to to adjuvant therapy? Would I still go to systemic therapy? I think this is a case with a precarinal lymph node where the answer is clearly yes, that this person is getting systemic therapy. I think that the overall there has always been a theoretical enthusiasm for neoadjuvant approaches in general, but this is a place where I borrow a lot from my colleague Tony Ribas in melanoma and his colleagues. They conducted, which I thought was a beautiful study, where basically they randomized patients, and the only randomization was where in your treatment course you got your tumor taken out. Did it get taken out before you started therapy, or did it get taken out after you'd already started the immunotherapy? And the outcomes were actually strikingly better in the patients who had the tumor still in. So,
interestingly, the exact same trial in breast cancer was completely negative.
Yeah.
And I think that admittedly, I don't follow the breast cancer literature as well as I do, but I think that also when you look at the kind of responses that have been seen in breast cancer to date with immunotherapy, they are not the sorts of things you've seen with melanoma.
Yeah, I wasn't talking so much about immunotherapy in breast cancer, but more, conceptually the way they literally did a study, NSABB 18, where they either gave neoadjuvant, this is not IO, neoadjuvant chemo or adjuvant chemo, no difference.
And I think the
Whereas
immunotherapy
and melanoma is a different story. I'm just, in a solid tumor, it didn't work, but here it did.
Yeah, and I think that part of the, at least theoretical appeal here is the idea that you still have that huge vat of antigen sitting there at the time of surgery. And so in a case like this where I know I'm going to be systemic therapy, the patient is at a high likelihood of benefit because of the high PD-L1. To me, this is an easy case to at least start with a chemoimmunotherapy approach. What to do after surgery, I think is a more difficult question, but I think that in reality, what's going to happen in practice is that we're, of course, going to actually see what happens to the patient. Corey mentioned complete pathologic response. If someone has that, it's going to alter your thinking considerably versus if they have a good response but don't completely eradicate pathologic evidence of the tumor, or if it looks like there was really very little benefit. And I think that those are the sorts of issues practitioners are going to be dealing with in the coming years.
So if they have a path CR, what do you do?
I would not give additional therapy.
Same.
And of course, is cell-free DNA an issue here, potentially? Corey?
An important study tool, not quite ready for prime time, but certainly is being incorporated in studies going forward that will assess various approaches to the post-resection period.
All right, let's talk about some data here.
So outcomes, again, in resectable disease obviously need to be better. If this were breast cancer, these numbers would be absolutely atrocious and unacceptable. Resectable disease, about 30% of all our patients. Locally advanced, maybe another 20%. Adjuvant cytotoxic platinum-based chemotherapy has been our standard for the last 20, 25 years, but it's a modest survival benefit, about 5.5%. And even in the earliest stage, 1B patients where you might give chemotherapy, up to half of these individuals will have disease recurrence or death. These are the phase 3 studies that have looked at immunotherapy in the resectable setting. We have 2 adjuvant trials, which I'll go over quickly. Empower 010, which mandated adjuvant chemo post-resection, and Keynote 091 are the PEARLS trial, where it was optional. And then several neoadjuvant or peri-adjuvant approaches. The only pure neoadjuvant trial was Checkmate 816. Every other trial, AG and Keynote 671, the NeoTorch with torpilimab, Checkmate 772 were both induction and post-resection, what we now call peri-adjuvant treatment. These are the data from Empower 010. Over 1,200 patients enrolled. Just over 1,000 ultimately underwent randomization post-surgery and adjuvant platinum-based chemo to either atezolizumab or best supportive care, or hierarchical primary endpoints. First in the stage 2 and 3A population that had PD-L1 positivity, then all randomized stage 2 and 3A patients, and finally intent to treat. And the curves shown in the upper right are the first group. And you see a fairly prominent 12% absolute improvement in 3-year disease-free survival, hazard ratio 0.66, and that separation occurs pretty early on. The greatest benefit seen in those with high PD-L1, 50% or higher, that hazard ratio goes down to 0.43. The 1 to 49% group, not as prominent, 0.82, and if you have no PD-L1, it's a wash. 3 years in that PD-L1, 50% or higher, it's a 25% absolute improvement in disease-free survival. Overall survival data are still immature, premature, but we do have hints, at least in that high PD-L1 group, of potential benefit, about a 17% absolute improvement at 4 to 5 years, with a hazard ratio that's under 0.5. For the group where the drug is approved, this PD-L1 positive stage 2 and 3A, that hazard ratio is 0.71. The PEARLS or Keynote 091 trial, very similar. Pembro for up to a year versus a placebo. After resection, platinum-based adjuvant treatment was encouraged but not mandated. Dual primary endpoints, disease-free survival in the overall population, and then also in those who are PD-L1 50% or higher. And here we have somewhat paradoxical results. The 1B to 3A all-comers cohort, the hazard ratio is 0.76, and the group we'd expect to benefit the most, it's actually higher. 0.82 with a p-value just in that group of 0.14. A lot of head scratching over this. It's been speculated that the placebo group, and at least in the high PD-L1 cohort, overperformed. We have no reason to believe that they would normally, but they seem to do a lot better than anticipated. They're otherwise completely balanced with respect to baseline demographics. Peri-adjuvant, Clearly better tolerated giving chemo up front rather than after surgery. Predictive biomarkers can be obtained pre-treatment. Immunotherapy, we believe, and certainly melanoma as an example, may be more effective with the tumor in situ with an intact immune microenvironment rather than post-resection. There's less time for clonal evolution and more homogeneous tumors, an opportunity for lesser lung resections. If we do neoadjuvant alone, abbreviated treatment, only 9 weeks rather than a full year of therapy, we have the capacity to assess the efficacy of treatment. And the pathologic data can help predict both prognosis and potentially guide post-op treatment. Here's the first trial, first randomized phase 3, 816, looking at nivo plus histology appropriate chemo for 3 cycles versus chemo alone in stage 1B through 3A. Again, the 1B group, 4 centimeters or higher without nodal involvement. Primary endpoints PCR by blinded independent path review, and EFS, again by blinded radiographic review. Striking benefit PCR rate, about a quarter of patients, 24% versus 2%. Major pathologic response, 37% versus 9%. You can see the waterfall plots on top favoring the nivolumab arm. Lesser resection and pneumonectomy rates were lower in the 3A group, 17% versus 30%. Slightly higher R0 resection rate in the nivo arm. If you look at event-free survival, clearly positive, about a 14% absolute improvement at 3 years, hazard ratio that's under 0.7. And the group that seems to benefit the most, as we've come to expect, are those with high PD-L1, where the hazard ratio is under 0.3. 772, T is the periadjuvant version of 816, so basically adding nivo out back after resection. All these patients get induction nivo with chemo. There's other minor nuanced changes. You look at the Checkmate 717, there's actually 4 cycles as opposed to 3 cycles in Checkmate 816, and they're also stratified by histology. You look at the 2 studies side by side, the PCR rates are identical, really calling into question whether you need that 4th cycle of chemo IO. The hazard ratio for event-free survival here is slightly better with the periadjuvant group 0.58 with lots of zeros in that p-value. And again, subgroup analysis, virtually every group benefiting, but greater benefit in stage 3, greater benefit in PD-L1 positive, particularly those with PD-L1 50% or higher, where the hazard ratio is 0.26. We have 2 other trials, AEGEAN and Keynote 671. AEGEAN looking at durva in the same setting, plus platinum-based chemo, 4 cycles versus platinum-based chemo alone, and again, durva out back versus placebo, and then Keynote 671, cisplatin-based treatment, cisgem for squam, cispem for non-squam, combined with pembro, otherwise the same basic study design, both positive. The PCR rates here are about 17, 18%. Hazard ratios, again, nice. You call this a pelican curve, I think. I call it fishtail curve.
Yeah, that's not a pelican. Pelican's got a way wide.
This is a pelican that hasn't quite eaten its prey yet. And again, this is the first trial to show a survival benefit. As reported at ESMO by Jonathan Spicer just this past year. Maybe this is the beginning of the pelican curve, I don't know. But certainly at 4 years, you see a 16% absolute improvement in survival, hazard ratio of 0.72. So early on, seeing a survival benefit. Here, it's sort of a wash whether we look at stage or PD-L1, the benefits are across the board. So at least for adjuvant, neo, and periadjuvant, Tezo and Pembro are both approved now in the US in the adjuvant setting. Tezo is restricted to PD-L1 positive stage 2 and 3A. Pembro's across the board, ironically. Neoadjuvant nivolumab with chemo, and of course Pembro with chemo as well in the periadjuvant period. Pembro being the only one showing a survival benefit. I think we need de-escalation studies in patients with past CRs and intensification trials in those who have something less than that.
Can I just ask, you use IOs, and people, I'll ask Eddie, do you use IOs in this situation of people with PD-1 negative?
So there are situations, certainly, in which I will use it in someone who has PD-L1 negative, but I think it does give me some pause. The data has generally not been as clearly impressive. I think someone with a high tumor mutation burden, I still think that that's a group that may benefit. But certainly if I have someone who's not been a smoker, who has PD-L1 less than 1, that is a group that I've been, that just looking across the data in this field, I'm less enthusiastic about the likely benefits in that patient population.
Okay, Corey, please continue.
Finish up real quick. Pacific, so now we're in locally advanced. Pacific rules the roost. 5-year absolute improvement in survival, about 11%. 20-month improvement in median survival. But remember, this is after you complete chemoradiation, so no progression during the prior chemoradiation, no untoward toxicity that would preclude durva in this setting. We've looked at our populations. About 30% of patients would never have made it onto Pacific after concurrent chemoradiation. The big issue here, again, is the low PD-L1 group. The hazard ratio is on the wrong side of the axis at 1.36. The Europeans have taken that to heart. In the EU, durva in the consolidation setting is approved only in PD-L1 positive. In the US, it's across the board. But you got to realize it's a post hoc analysis. Fewer than 60% actually had adequate tissue for PD-L1 assessment. Small numbers, only about 20% of those accrued seem to be PD-L1 0. And over time, at least for EFS, that hazard ratio, or for survival, that hazard ratio has dropped from 1.36 to 1.14. Finally, the COAST trial is looking at adding other agents. Oleclumab inhibits CD73, another checkpoint on the immune axis. Monalizumab blocks NKG2A. So combining that with durva versus durva alone, randomized phase 2, and you see the combination or combinatorial approaches, at least in this study, resulting in better disease-free or progression-free survival. But note how poorly the control arm did here. It was only about 6 months. So that has turned into a phase 3. Pacific 9, I believe, is about half accrued, looking at those two arms versus durva. One last aside.
So it's like a 3-arm trial?
Yes. And the big lung trial from the Hoosier Oncology group, emanating from there, but other institutions, actually looked at ipi-nivo in this setting. So nivo alone or ipi-nivo for 6 months. Not much difference in either PFS or OS, but a lot more toxicity, a lot more pneumonitis, a lot more grade 3 AEs. So no further treatment benefit for that. Finally, just this past week, Pacific 2 was presented. This is durva, both concurrent and consolidative, versus just chemoradiation alone. And many of us have questioned the ethics of this. This was actually done in resource-constrained countries where durva simply wasn't available. So sort of a second and third world study. All we had up until this past week was the press release where it did not achieve statistical significance for the primary endpoint, which really left me incredulous. If consolidative is better, shouldn't both together be better yet? And yet here, something was nullified, and we believe it may be infections. And that has major bearing on 5181, which just a month ago completed accrual, a true study comparing Pacific 1 versus Pacific 2. So consolidative durva following chemoradiation versus both concurrent and consolidative. So this study, again, stay tuned. Probably in the next year or two, we'll see the results.
You were saying something about infections?
Apparently, I was trying to get the slides, but literally it was presented like 2 days ago. Heightened infections and pneumonitis. So there may be issues. Again, giving immunotherapy concurrently with chemoradiation, you're playing with fire.
So in a second, I want Lowell to present his 70-year-old man. But first, Lowell, any questions about that? What's your experience been with the post-chemoradiation, durvalumab? Any questions about Corey's presentation?
No, I mean, I think it certainly is standard of care. It's become our standard of care. I'm sure all the docs in the room are using the same thing. I mean, it is, it's not without, difficulties too. I had a patient in clinic this week who about 2 months into Pacific treatment after finishing thing got insulin requiring diabetes, type 1 diabetes.
Wow.
And his wife was extremely unhappy this week because of the cost of the not so much him having to be on insulin, he's on metformin too, and luckily I was able to get an endocrinologist to see him. And interestingly, he's not obese and had one little glucose, just a teeny bit up, maybe a year or two ago, but all his glucoses during his chemo were fine while he was getting chemo RT, but now he's got type 1 diabetes, and all his foods are very expensive. His wife was telling me it's $7 for a diabetic cereal and this and that, and how much it is.
And that side effect's permanent.
And that's a permanent side effect. And I had to tell him that today or this week.
Yeah, and we've found that to be a particularly difficult diabetes. Obviously,
very brittle
diabetes we see in our clinics all the time.
From IOs.
This doesn't feel like the sort of thing that just sort of goes on their med history, like some of our patients with diabetes, in the context of the fact that they have metastatic or advanced, in this maybe not metastatic, but at least advanced.
Trying to get a 70-year-old just to eat a diabetic diet when they've never done it their whole life is not going to be an easy thing.
Interesting. So let's hear about your 70-year-old man.
Okay. So this is another sort of adverse effect you can see with IO. So this is a 70-year-old man who had COPD and moderately severe rheumatoid arthritis. He'd been on treatment, seeing a rheumatologist. He had stage 1 squamous lung cancer resected in 2019. It was I think a 1A, and didn't get any adjuvant treatment. He did well until 2023 when he progressed in thoracic nodes, bilateral lung nodules, was biopsied, and it was again squamous cell, and was PD-L1 positive. Interestingly, he had KEAP1 and STK11 mutations, and he had on liquid biopsies, TMB was about 14. So
before you go any farther, Eddie, can we believe liquid biopsies, TMBs?
So my bias is that you can believe a liquid biopsy TMB if it is quite high like this. I think that would
14?
At 14 I would be comfortable. The problem becomes when it starts to get low, you don't know whether or not that's because of sample quality or not. And also, I don't have exact confidence in how that would portray. But if it were 14, I would feel that that's a real finding of some sort, that it is a high TMB case.
And so I guess it's a little bit complicated because this patient has rheumatoid arthritis, right, Lowell?
Yes, and his rheumatologist stopped his medication. The non-generic name was Humira, and he got started on carbotaxol and Pembro. He did quite well, but once the chemo part stopped and he continued on just the Pembro, you can probably guess the punchline. He started to get a lot of joint aches. I saw him in clinic this week. He is miserable in his nodes, in his joints, and his CT scan showed his nodes had a reasonable response to treatment. He's still doing well from the oncology standpoint, but from the rheumatology standpoint, he was doing quite poorly. I saw him this week, and I had to put him on some steroids and get him back to see his rheumatologist, who gave me a big list of, well, can they get this medication? Can they get that medication? Half of which I had never even heard of. So if you don't keep up with the rheumatology literature very closely, there's a lot of new drugs out and different agents. So it's a tough problem. So I saw him this week. I'm holding off making any decision on him. I gave him some fluids in the clinic and some further steroids.
So Corey, any comments? And also the issue of, I heard somebody say that what you may see in this situation is the patient's okay while the chemo is going, but when you stop the chemo, is that more typical?
The chemo is probably controlling
Exactly.
the rheumatoid arthritis.
Exactly.
Right. So this patient would have never made it to Keynote 189. Again, the eligibility were very strict. They excluded people with active collagen and vascular disease. This person was on immune suppressant therapy. And yet we are treating these folks. These are the patients we see. This is real world experience. I pretty much do the same as you. I'd pause the Pembro. I don't kid around. I'll give full dose steroids, a mg per kg, at least to start, taper down. The studies now allow doses of up to 10 milligrams of prednisone. I have found that to be a sweet spot, sort of chronic 5-10 milligrams, where I can control both the arthritis and yet eventually resume the pembrolizumab and continue that and still eke out a benefit. And I do the same for dermatologic toxicity. I don't do that for other major organ toxicities, myocarditis or et cetera.
So Eddie, I'm curious, we've had the issue of, the concern theoretically of giving corticosteroids in the face of immune therapy. I saw, sometimes I can't even remember where I hear things. I think it was a GI study, but it was a randomized study of chemo plus IO where they had NAB versus paclitaxel, and there was a difference. Chemo plus IO, and the patients did better on the NAB, presumably because they didn't have, steroids for acute GI toxicity. Has that been looked at?
So in some ways it has, although not in a randomized fashion. So in fact, this patient would not be Keynote 189. This is a squamous cell patient, so it'd be the Keynote 407. And the Keynote 407 did have the option of giving patients either standard paclitaxel or nab-paclitaxel. I can't give you the numbers off the top of my head, but the nab-paclitaxel did not look better in that study than the paclitaxel. It was not a randomized decision. It was an individual investigator's choice, but it did not look better.
So just wondering. All right, let's take a look at some data again. And Eddie, you're going to talk to us about some other emerging therapeutic options, and I think we'll hear a little bit about ADCs for a change.
Exactly. As I'm watching the other talks, I'm like, maybe I don't need to go through the picture of the antibody drug conjugate, what it looks like. So my topic will be current management of metastatic non-small cell lung cancer without a targetable mutation. Here you see my disclosures. So I'll start with a case, which is a 64-year-old patient, former smoker who presented with chest pain, dyspnea, palpitations, and hypoxia. The patient was actually quite ill at the time of presentation with a large mass and a large pleural effusion that was actually shifting the mediastinum over that led to admission to the ICU. Need to have a chest tube placed. Biopsy did reveal at that time a PD-L1 of 90%. There were no actionable genomic alterations, and a brain MRI did not show evidence of brain metastases. There were, however, extensive metastases to the body, including bone, liver, and adrenal glands. The patient with the drainage was able to be stabilized for discharge at the time. We were not really able to give immunotherapy in the hospital setting, and so we were able to get him to clinic. This is a case where we did end up initiating carboplatin, pemetrexed, and pembrolizumab, despite the very high PD-L1 expression.
And no targetable mutations?
That is correct. There were no targetable mutations.
Corey, one of the scenarios that we've talked a lot about the last few years is a patient who presents extremely ill. I don't know, it sounds like this patient may be not quite that ill, who really needs to be treated immediately in the ICU, et cetera. And this issue of do you give an IO in that situation, particularly when you don't know the genomic status. What we've been hearing from you all is hold off until you have the genomic workup.
At least start chemo. And in the inpatient setting, if you've got to start it in our institution, we end up with old-fashioned paclitaxel and carbo, simply because the other agents won't be reimbursed. I'm sure that's going to change soon with PEM. But as soon as they're outpatient, we graft the immunotherapy on. Once we know that their marker status is negative. And remember, you got two ways to look at marker status, both tissue and liquid. Liquid turnaround is a week. And we now have an in-house assay called Tempus. We look for the 9 major genetic abnormalities. If that's negative and liquid's negative, we'll go ahead. We won't necessarily wait for the conventional tissue NGS. This patient's sick, high PD-L1. We may just have one shot on goal. I would give both chemo and pembro.
Suppose the patient's a non-smoker.
No. This patient did have a significant smoking history.
But I mean, that makes a difference to you.
Yeah, it makes a significant
difference.
difference.
That's one thing we noticed too when we start. We present these scenarios all the time to people, and then we start adding in smoker and non-smoker. We saw you guys responded differently, so that's why I mentioned that. Okay, let's continue.
So, in addition to not being exactly the same brightness level, the scans did also improve significantly after 4 cycles of therapy. And the patient did quite well. He actually was a little over a year into his treatment at the time of the onset of the pandemic. Is an educated patient, decided that with him doing well at that point, it was not worth the risk, at least initially, of coming into the clinic in someone who was stable at that point. I think it was like 16 months post initiation of therapy. After vaccination, though, the patient was interested in restarting the pembrolizumab alone, but still was concerned about the pemetrexed.
What happened?
The patient is doing very well at this point.
Really?
Yeah, he's continuing to do clinically very well. And one of the things I was wondering if I should even say it, but I still have him on pembrolizumab years out.
Wow.
Now,
It's been 5 years?
Yeah, and I'm perhaps an outlier in this.
It could be a world's
part.
record.
Well, no, it's not a world's record. I can tell you how I know that for sure, is that I probably have a particular bias on this, is that we put a very large number of patients on the Keynote-001 study, the original pembrolizumab study. This, of course, was a phase 1 study, and the way it was set up, like most phase 1 studies, you just treat people forever, and so we do. At least once a month, am seeing somebody who's now in year 12 of their treatment. There is some randomized data that would indicate that stopping at a year is not as good as continuing, and it doesn't take very much from a toxicity perspective to make me stop.
So we got a bunch of fellows here. Would you like to kind of put in perspective this case?
Yeah. I think that's one of the things that's just really, incredibly interesting to me. When I started my practice, I basically took whatever would be available that someone would hire me for at the academic center. So I was doing lung and pancreas. And the two clinics look pretty much, yeah, exactly. You could tell where I ranked in my fellowship class to get assigned those two. And the outcomes were really pretty much the same. They were a little better in lung, but you didn't have a meaning, you didn't feel very different between the two clinics. And now my clinic feels remarkably different. The idea that I have patients that I'm coming and asking them how their golf game is, how their grandkids who are now in grade school that they didn't have when they started therapy. Those were things that were just unthinkable at the time.
These data blow my mind. Having been there back in the 80s and 90s when we were lucky to see a patient live a year, let alone 2 or 3 years, we're seeing 5-year survival. A lot of these folks are acting like they're cured.
So how about it from the community perspective? You feel like you're seeing this too, Lowell?
Absolutely. We have patients that are, off treatment now for a number of years that are still doing well. I generally, personally, have not gone beyond the 2 years. I'd be interested in what the audience in general does.
I think most people, I don't think are going beyond 2 years.
I have one person I saw in clinic last week who's a veteran, and he's afraid of losing his Camp Lejeune benefits, even though he's been in. So he's now well into his 3rd year. He insists that his VA benefits are going to go away if I ever stop treatment. So he's having no side effects, but he's still getting something. So, but in general, I generally stop. I think that at Florida Cancer Specialists, that's been our general recommendations. But I'll be interested to. What the
it seems like I hear that a lot. All right, let's keep going.
Yeah, so you now have 3 drugs that have an approval at patients who have high PD-L1 expression, 50% or greater, 2 PD-1 inhibitors and 1 PD-L1 inhibitor. The only thing I'll note in these that makes any of them different is at least there's some concern that in the Empower 110 in the more recent updates, the survival doesn't look quite as good. It's no longer, wouldn't reach the bar of statistical significance, although based on study design, that never sort of gets taken away from it. Pembro is unique amongst these in that it has an approval at the 1% cut point, not only at the 50% cut point, but for most of us in academic thoracic oncology, we don't love this indication. You can see the data here from the study that led to the approval at the 1% cut point. This was largely done exclusively done, in fact, outside the United States, where patients would not be able to cross over in most cases to an immune checkpoint inhibitor. And you can see that in the people who are added here, the 1 to 49% patients, there really was not a huge suggestion of a survival benefit. But there are outlier cases where clearly it does make sense.
People in their 90s?
I'm sorry, what was
people in their 90s?
And that's the one thing, thank you for asking, I'll go back to this. So I think that is something that also does differ a little bit from an academic center from there are some patients in standard practice based on being elderly or performance status where this may be their only real option for treatment. And I think in that case, it probably does offer an important role. If I had a young, healthy patient, I wouldn't view it. I wouldn't view it that way. But you're absolutely right. For someone in their 90-year-old, reasonably good performance status, I still would be concerned about the toxicity of chemotherapy. This may offer them a good benefit. And as you can imagine, none of these things are perfect, right? If you have someone who has a high the only other really relevant biomarker in lung cancer is tumor mutation burden. You had someone with a high tumor mutation burden, they have a PD-L1 of 40%. Maybe it's reasonable in that case to think, particularly in an elderly patient, of starting with single-agent pembrolizumab. So the only other approved non-chemotherapy regimens are based on the Checkmate 227 study. This is a particularly complex study. I sometimes call it a 6-arm, 4-bin design because so and interestingly, to interpret it, there is the group of people who have PD-L1 expression on top. They got either Nivo and Ipi, chemo, or Nivo alone. Then below, the only thing that was a difference is instead of getting Nivo, they got Nivo plus chemo. Interestingly, the design was they decided that they expected the benefit really to be in the patients who had PD-L1 expression. So when they submitted this for regulatory approval, that's what they asked to be looked at. And so they did end up getting regulatory approval for nivolumab, ipilimumab in that group. And now we have 5-year survival that shows really quite good 5-year outcomes in this patient population who got nivolumab and ipilimumab. Certainly better than the control arm of chemotherapy, and certainly looks also better than the nivolumab alone arm. This is a little hard to reconcile with data of a study then that was conducted of pembrolizumab with or without ipilimumab. This is only for patients with high PD-L1 expression. But what you can see here is that these curves are superimposable, and that really there's not much suggestion of adding anything but toxicity in the high PD-L1 cases, leaving the potential that there's some benefit in those 1 to 49% patients, but we do get into the difficulty of cross-trial comparison. The similar results, though, which were a little bit more surprising in the patients with PD-L1 less than 1%. Here you can see the Nivo-Ipi performing again quite well. Chemo not performing as well, and Nivo chemo not performing as well. But I think also the caveat for both of these, Nivo alone or Nivo chemo, are also not approved in the frontline setting, but they did underperform the nivolumab ipilimumab arm. These are in contrast to, at least in treatment choice situation, versus pembrolizumab plus chemo. This is a combination of the two studies that we discussed earlier, the Keynote 189 and 407 studies for non-squamous and squamous cell carcinoma, respectively. And what you can see here is overall survival on the left, progression-free survival on the right, showing a significant group of patients who are doing quite well 5 years out. The Empower Lung 3 study, I think it's particularly confusing that for some reason the Roche decided to name their suite of studies Empower and Regeneron's Empower. But this is actually cemiplimab, and so this is their combination with chemotherapy. The data also looks certainly quite good. We don't have as long-term follow-up just because this study was conducted later. This study, which is Empower 150, is a bit unique in that, unlike the other studies, in addition to chemotherapy and an inhibitor of the PD-1 or PD-L1 interaction, this incorporated a bevacizumab, an anti-angiogenic. This regimen did look better than the same regimen without the atezolizumab. I think what has been difficult as a community for us to sort out to date is what the additional anti-angiogenic is doing for the efficacy of the regimen. Another regimen that is an option in the frontline setting is a Checkmate 9LA. This combines chemotherapy and ipilimumab, nivolumab, randomizing patients to chemo with or without nivolumab and ipilimumab. And here you can see the 4-year data. PD-L1 positive on the left, PD-L1 negative on the other side, and you can see that the overall survival is the endpoint that's being assessed here. I think that this is one of the interesting things that that comes up. There's a lot of on practitioners. There's a lot of push to do a lot of cross-trial comparisons among all of these studies. But I think you have to remember that the study populations may not all be the same in this, and it can be quite difficult. And in fact, if you look at the long-term outcomes of the PD-L1 greater than 1 patients, it actually looks a little worse in the CheckMate 9LA, which gets chemo, than the same population in the CheckMate 227, which only gets nivolumab and ipilimumab. So to me, does it mean that the chemo is harmful? I doubt it, but I just think it is a reminder that it is difficult to take a bunch of studies and try and find the one that has the longest 5-year survival rate, because there are unique differences between the studies. And the additional study that is added to this is Poseidon. This is a study where the PD-L1 inhibitor in this case is durvalumab, and the PD-1 inhibitor is tremelimumab. And this is based on the study where there also was a durvalumab plus chemotherapy arm. That arm looked somewhat similar to the 4-drug regimen, but did not hit its statistical endpoint, whereas the 4-drug regimen did hit its statistical endpoint. We recently have had an update on the 5-year outcome data showing again a substantial group of patients who continues to be alive and presumably doing well 5 years out. We have only a short amount of time to talk about previously treated patients. I show this slide. Of course, this is from a paper that I wrote, but in case you think that it's up here because of that, I wish that I weren't having to present on it anymore, because I think I wish that the field had moved on from docetaxel, but in many respects it has not. So docetaxel-based therapies remain the standard of care. Ramucirumab is sometimes incorporated based on an improvement in overall survival and progression-free survival that fall into about the month-and-a-half regimen. When this initially came out, I and others involved in it took a lot of flack for the sort of limited survival benefit, but many of the things that we've been quite excited about subsequently have really shown less meaningful benefit, if at all. As I mentioned before, I probably don't need to at this point go through what an ADC looks like to you. We don't have a ton of comparative data looking at the ADCs yet, but the one that we do have is TROPION-Lung01, and in that study was presented by my colleague Aaron Lisberg. Patients were randomized to docetaxel alone, so without ramucirumab, versus datopotamab deruxtecan, an antibody drug conjugate targeting TROP2. It was a dual primary endpoint, progression-free survival and overall survival. This is a particularly interesting data set to see in many respects, because it is not as straightforward as many data sets. So when my colleague was presenting at ESMO, I was in the second row, and I heard the person in the front row look at these PFS curves and say, "That's 3 weeks." So that is the difference between the two curves on this. Now, in general, that's not an entirely fair way of looking at these data sets. If you extrapolate towards the 50% on the y-axis, what you'll see is that the 50% actually is the absolute most unfortunate time for comparing these curves for datopotamab deruxtecan. The curves are nearly together at that point, much more than is what the reality for what these curves actually look like. But nonetheless, it was not as robust as many had hoped for, but also was associated with a very interesting finding. In squamous cell carcinoma, not only was the benefit not as robust, but there was at least a suggestion of potential harm for progression-free survival when datopotamab deruxtecan was given instead of docetaxel. On the other hand, when you look at the non-squamous curve, those curves look pretty good, and the person in the row in front of me wouldn't have been complaining about 3 weeks difference. And so I think that what's left now is to see what the FDA thinks of these data. I think that if you, again, look at the non-squamous alone, it looks like a reasonable group, a reasonable benefit, but I think that we will see. The other thing is that the toxicity profile of datopotamab deruxtecan versus docetaxel is clearly different. Whether that means it is better or not, I think when you talk to different people, you'll get ranges of opinions from clearly better to probably not better. And I think that obviously, as people start to use this in lung cancer patients, I think individual practitioners are going to make their own decisions. We have used a lot of it, as you can imagine, with my colleague presenting it. My bias is that it is a better toxicity profile as compared to docetaxel. But as I say, that puts me sort of in the middle of a range of views that you would get if you talk to different people. In terms of the safety summary, the one that gets talked about a lot, of course, is that there is a rate, although small but real, of fatal ILD, and that is of concern. But there are also concerns that are bothersome to the patient, including mucositis and some ophthalmologic studies. But if it were to be approved, I think that there still may be a significant enthusiasm. In my practice, I would have enthusiasm for it. So
we were talking about the data last night with the breast people, and also about, because I think breast and lung were presented at the same time at ESMO in terms of tolerability. They were saying, because I've been about the mucositis, that the sort of swish, oral steroid mouthwash works. Corey, have you used
We've used that.
Does it work?
Both in ADCs and also with TKIs, to some extent, yes.
And Corey, what about this histology thing? Any sort of biologic explanation?
Not that I'm aware of. This was totally unanticipated.
And, would you want to use it based on histology, or you think you need another study?
I suspect the approval, if it comes, is going to be based on histology.
Is that what you're thinking,
would not
Eddie?
use it in squamous cell for sure.
I don't know the answer, but if I were at the company trying to make this decision, I wouldn't ask for an approval in a setting where the hazard ratio was 1.4 or whatever it was.
I mean, would you like to use it based on histology?
I would only use it in my practice based in non-squamous, recognizing, as sort of Corey's alluding to, that that's the data we got from the study. It doesn't mean if you were to replicate the study, that's exactly what it would look like in the non-squamous either the next time, but that's where I would want to use it, yes.
Do you see this coming into practice?
Yeah, I think it's a regulatory decision. I think that, as I mentioned before, I had anticipated, in many ways hoped, that these docetaxel-based regimens would be a thing of the past by now. There's so much progress we've made in other areas that the fact that I'm still presenting that data from the REVEL study seems really out of place overall. That being said, what I may say is that we may have underestimated docetaxel, and in fact, many of the immunotherapy studies that I've been involved in that have looked at comparing to docetaxel, one of the problems they've had, they may have had some benefit, but they really underestimated that for some reason that we don't understand, the survival in the docetaxel arms of those studies keeps going up over time, which I don't entirely get, but it's what we see.
All right. Well, I want to thank you all for coming here this afternoon. Thank you. We're going to start out with multiple myeloma bright and early tomorrow morning. Have a great night.